get the so I just need to make sure share screen.
Share screen.
Let me just go to share screen. This is what we want, isn't it? Then she'll put the slideshow on. Everybody see that?
Yeah, that's great. Thank
Let's
you.
go back. How do I go back?
Jumping the gun, love. There we go. So hello, good morning. Yeah, so this is a presentation on disordered eating from myself, Gemma Forder, and my colleague.
I'm Laura Rayner. So we're both the clinical nurse specialists within the eating disorder pathway from Solent West Cams.
They are.
We haven't put Solent West Cams
No,
on there.
we didn't, did we? Well, we've got Solent West eating, so that'll do. Right, how do we move on to the next one? You're good at this
like that. Yeah.
Okay, I'll make you. So today's learning outcomes are we're going to look at what differentiates disordered eating from a clinical eating disorder. So by the clinical eating disorder, we mean those like anorexia, bulimia. They're typically what we would see most of. What can trigger disordered eating? The symptoms and when to be concerned. Information about other eating disorders. So we'll share a little bit about kind of what you see with anorexia and what you see with bulimia. Are there any risks to disordered eating? What sort of support there is and when to access it, and strategies to support any eating issues. We thought that would be helpful. Okay, sorry, there's quite a lot of wording, just because it can be very hard to summarize it in such a short, small amount. So we've put on either side, we've got clinical eating disorder, and then on the other side, we're sort of summarizing disordered eating. So this is trying to look at the difference between them. So, sorry, my throat is like awful.
So this one is actually more of a formal kind of quote or what that come from the ICD-11, which is the diagnostic tool for mental health disorders. This is specifically for eating and eating disorders and feeding. So it's very, very broad. But it's saying that it's an abnormal eating or feeding behaviours that are not best explained by any other condition. So they're not developmentally appropriate or culturally sanctioned, and they involve the abnormal eating behaviour, preoccupation with food, as well as prominent body weight and shape concerns. And so, like Gemma was saying, the main ones we see within CAMS are anorexia nervosa and bulimia nervosa, and the other specified eating disorder, OFSFED, and ARFID. Obviously, we see. We binge eating disorder. I mean, we see bits of it, but there's not really a clear treatment. There's no evidence-based treatment really for it, other than self-help, I think. So it's not one that we see that often. But those the four main ones are anorexia, bulimia, OFSFED, and the ARFID.
Can I ask what are you? So I might be jumping the gun. What OFSFED is? I haven't heard of that one before.
We will go into more detail in a bit.
Right, all right, thank you.
It's basically the ones that don't fit the boxes of anorexia and bulimia. So they're very, very similar, but because of it falling into that ICD-11, where they've got that strict criteria, and not everyone fits those boxes, but still warrant an eating disorder diagnosis.
Okay.
So it's those that fit into that. It used to be called EDMOS.
Yes.
Okay.
The eating disorder
not otherwise
specified. Yeah, I quite like that, to be honest.
Yeah.
There we go.
Thank you.
Then, so we will go into those. And then disordered eating, I'm kind of losing my right. Oh, there we go. Okay. So disordered eating, it can take up a number of different forms and can overlap with characteristics of eating disorders. So many young people with disordered eating don't necessarily fit the criteria for an eating disorder such as anorexia or bulimia nervosa. There'll be sort of milder forms of that disorder that they're sort of presenting with. So it's not necessarily a diagnosis. So we would sort of say that someone will have disordered eating, but that's not really a diagnosis in itself. That's kind of an ICD-10-11. So some of the eating behaviours can be attributed to issues with emotional regulation, and it's not about them trying to influence their weight or shape. which is what you would see with anorexia nervosa, is that they've got that drive about their weight and what that number has, you know, they have a goal of what number they have to be, or the shape, they have to be a certain shape or fit in a certain size clothing. You wouldn't get that with someone that's disordered with their eating. They wouldn't be so obsessed about it. It becomes their kind of coping strategy really around their emotional dysregulation. Many other mental health conditions highlight changes in eating behaviour and appetite. So someone that's really clinically depressed could become quite disordered with their eating because they haven't got that motivation, that drive. They kind of, you know, they're so clinically depressed that they've kind of abandoned all those daily living sort of things, such as their hygiene or their daily routine of getting up in the day and going out and about. Their sleep cycles change, so then their eating also becomes quite disordered and changing. And the low weight itself doesn't always determine an eating disorder diagnosis. So this kind of
summarizes it quite well here. So what we're saying is, just because it might not fit in that eating disorder diagnosis book doesn't mean to say it's not less, you know, it could still be really serious. And we, as an eating disorder service, you know, would still assess and consider whether it's appropriate for us to treat. We do treat young people with disordered eating, absolutely, if it's appropriate. We may be seeking support from our colleagues out in core CAMs, you know, we might be working in partnership, but, you know, so it might not fit that ICD-11 diagnostic tool. However, you know, we still see it as significant, and, you know, it may need treating by the service. So yeah, this summarizes it. So with disordered eating, there's it doesn't fit a diagnosis criteria, but there may be, you know, although it might not be the sole reason. So what Gemma was saying with anorexia, that is, you know, but they still may have that weight and shape. And we know that because actually if a young person's starving themselves and not eating properly, biologically they will end up having those psychological symptoms of wanting to alter their weight and shape. So actually if we can try and improve their eating and eating regular, that actually might help with the thinking around the weight and shape. So we'd see, again, with the disordered eating, you're going to be seeing their altered eating behaviour, and the risk is they may start off with disordered eating and then it might fall into a full-blown eating disorder that could then meet a mental health diagnosis. So, you know, the treatment, what's important within our CAMS eating disorder pathway is that it's early intervention. So if we do see any signs, then if we can try and get in there and treat it, the better outcome that would be for that young person, so it doesn't go into one of these eating disorder diagnoses. So yeah, we see, you know, it's still valid, you know, and it still requires support. So yeah,
we still want to unpick it as well to make sure that they aren't starting to get those disordered thoughts like an eating disorder. I'll try. So in summary, what distinguishes disordered eating from a diagnosable eating disorder is mainly about the degree and the amount of distress that changes to eating, weight or behaviour evokes. We've kind of found this and thought actually that really summarised it quite nicely, because I kind of feel, especially being in this field for a long time, we are noticing a lot of young people, it feels like it's become kind of acceptable for a lot of them to be disordered with their eating. And by that means not even having lunch. There's so many of them that go to school and they're not even having lunch, and then it's not about the drive to lose the weight, or because they don't want that food because it's full of carbohydrates or anything like that. It's because it's become quite acceptable to not eat in front of each other and to do other things, and there's always like endless excuses. So
especially the whole breakfast thing. I mean, the amount of times we see a young person that said, I've never eaten breakfast.
I just can't cope with that.
Yeah.
So an eating disorder is when actually it's not about this kind of blasé sort of attitude. It is, they are so rigid and so stuck with their thoughts around that eating this food will make them put on weight. Eating this food is going to affect how they feel about themselves, and it's about what distress that brings and what impact that has on their lives, really, and not just for them, also about the family, because then their family with having to manage this becomes so entrenched, don't they, and so kind of everything's centered around food. So that's what we kind of mean with distress. So if someone engages in disordered eating behaviors on a majority of days, or experiences distress and anxiety when they are unable to use these behaviors, or what they have chosen not to, it's likely that they may be diagnosed with an eating disorder.
But like I said, sometimes we'll get a referral in and it's not clear whether it is disordered eating or whether it's something else that's kind of driving the dysregulated eating pattern. And, you know, it's always best for us to actually, you know, hear the young person's voice, assess it, and then decide, because often, you know, with referrals, you know, it's might have been discussed with the family and the triage calls with the family, and actually we're not hearing the young person. So, you know, the majority of the time, you know, we will assess and make a decision based on that assessment, and then consult our colleagues from core CAMS as well, if, you know, thinking about what is the most appropriate treatment pathway for them. I think we'll go into more detail about that in a minute. So yeah, so some triggers around disordered eating. So we've kind of touched on these already, but, you know, the list is endless really. But so depression, anxiety, and emotional dysregulation. So depression, we know, can impact on a young person's appetite, and them just not feeling hungry, and, you know, just not having the motivation to eat. That can impact on their eating. Anxiety, you know, full of adrenaline, you know, that can stop a young person from wanting to eat. And then we get the emotional dysregulation, where actually it's a coping strategy to not eat. So actually they may think, you know, this is a way of punishing myself, or actually if I restrict, this is actually going to make me feel more in control of something that I feel completely out of control in my life. A young person may be stopping eating as a way of trying to end their life, or as a way of self-harm. We see a lot of young people with having experienced trauma. Yeah, absolutely. Emotional dysregulation can come with trauma, and yeah, that can be a trigger for disordered eating. Emetophobia, which is a fear of vomiting. That's quite a big one really with our young people, you know, our really younger age, isn't it? You know,
they may have experienced quite a horrible stomach bug or something, which resulted in vomiting, and then that has kind of then affected their relationship with eating food following that, and it's then become, it might be about the food that made the meal, but then becoming bigger and becoming more food groups, and that, yeah, I see that.
And that's it's quite a difficult one for us as well, isn't it? Because they kind of do fit into our pathway, in the sense that we can kind of treat the, you know, with our dietitian and support them with the kind of the weight restoration side of things, but actually psychologically they kind of fit more into the kind of the anxiety pathway, needing CBT side of things, which would be a completely different therapy than what, you know, you would treat for anorexia. So we kind of, with emetophobia, we may have to work alongside our core CAMS colleagues to offer that kind of that therapy, but they'll still stay with us with the kind
weight gain, and the kind of trying to help maybe the psychoeducation, which you wouldn't necessarily get on the other pathway.
So yeah, it's handy that we kind of fit in our in core CAMS, that we can reach out to our other colleagues as well. Family dynamics, so any kind of social difficulties, I guess that would come under sort of mental health within the family, you know, all of those kind of things that could impact on a young person's eating. Stresses in education, bereavement and loss, autism, traits of autism, ADHD, can all kind of impact on eating. And then we've got the social media, diet culture, and the bullying as well. And yeah, this is just a few examples. I don't know if the pictures impacting on what you can see. Is that, if I move that, I don't know if you see our screen completely.
No, it's all very clear.
That's good. That's good.
So yeah, so these are just some of the triggers.
Yeah, absolutely not all of them.
No.
Yeah. So symptoms of disordered eating. So some behaviors that you might kind of see with disordered eating is this rigid dieting, or the frequent limitation of the amount or type of food that they're eating. You may kind of see binge eating, so frequent or occasional loss of control of eating that causes the guilt, shame, or distress about having binged on some food. And by binge eating, we kind of sort of mean, well, everyone's got a different interpretation of what they feel is a binge, but a young person may feel that a binge is the fact that they've not eaten for most of the day, and then they've had a really, really big meal. It was a normal meal, but it was a big amount of meal. Or it might be binge eating is having had kind of lots of snacks, crisps, and just needed that sort of sugar rush because they hadn't really been eating regularly.
And it's that eating very quickly and actually feeling quite out of control, isn't it? Eating very quickly, very secretively, kind of hiding crisp packets and things like that, isn't it?
Absolutely. And then purging is kind of having the need to try and get rid of the calories that they may have sort of eaten. So there'll be like self-induced vomiting, excessive exercise, or using diet pills and laxatives to kind of get rid, to eliminate. Loads of writing. It'd be good for you to get. We'll send these so that you've got it available to you. So symptoms of disordered eating continued. So body weight and shape being central to self-esteem or self-worth. So a lot of it would be around not feeling worthy, really feeling quite down on themselves, not having a lot of confidence. We see that quite often, and then they sort of feel that their body weight and shape, if that changes, that would help improve how they feel about themselves. That then goes into kind of like negative body image, and they've got a disturbance in perception of body image. So they're actually really thinking that they're bigger than what they really are. Rigid exercise routine, combined with the extreme guilt or anxiety if they don't follow this routine. Having obsessive calorie counting or rules around calories. So I can only eat this slice of cake if I've done 500 press ups or something. That would be kind of like the mentality.
I'm only going to eat once in 24 hours and I can't eat that.
So having those rules that they stick by. Having anxiety about or having an avoidance over certain foods or certain food groups. So might be really anxious about having milk, for example, and cheese, so the kind of dairy products, because of believing that they're high caloried and absolutely can't have that. Or carbohydrates is quite a common one, so I'll avoid breads and crisps and pasta because they're high calories. So being quite sort of stuck with, I will make sure I won't have those. A rigid approach to eating, such as only eating certain foods or being really inflexible with meal times, refusal to eat in restaurants or outside of their own home. So that kind of explains it in that. Again, rules that I'll only eat that one thing if I know I can go to the gym later. So recurrent episodes of night eating. So we do kind of see with those that are disordered eating, if they've not eaten through the day, thinking that I haven't got time, or it's becoming quite a socially normal, like you said, wasn't it, about not having breakfast, they won't have lunch, then they have that need to eat later on, and then it becomes a night eating kind of pattern, doesn't it, really?
And some young people, who have had trauma or who are on the autistic spectrum actually don't want to eat in front of people, not even their families, and so they then take themselves off to their room, and if they have got this kind of disordered eating kind of thing of concern around their body shape as well, they might not, they might be thinking, if I eat that, they're going to think I'm fat. So then they're just restricting, but then they're getting so hungry because their body is physically saying, like, you need to eat. So then they're kind of eating quite secretively, and eating at night is a way that they can do that.
So having distress or anxiety associated with food, and distress or anxiety related to the change of any aspect of their current eating pattern.
So it's a very big list, really.
It is.
So when to be concerned. So with, there's heightened distress around, you're noticing around meal times, eating, you're just, saying, if you had your breakfast, and you're getting kind of real.
It's becoming hostile. A battle, isn't it? We hear from families that it's becoming quite a battle for them to get their young person to eat, and even talking about food, they're instantly getting that kind of that fight back, that sort of snarkiness. That's what we would kind of say is heightened distress.
we'd be really concerned for a young person as well if they've had, you know, literally no food for 2 or more days. That comes in our medical emergency. So we have a risk assessment tool that we use for a young person who is under our pathway, and we're assessing their medical, physical risks. So that comes up in one of the risk assessment aspects of the tool. Is, you know, it's quite a risk if they're not, you know, if they haven't eaten anything for 2 or more days. That will be raising an alert, really, that we should be concerned. That continuous weight loss over time, or weight loss over a short period of time, you know, young people we've seen can lose quite a lot of weight over a short period of time. So you're noticing some weight loss. Actually, you probably need to be, you know, thinking about getting, you know, them assessed, or thinking about physical health assessment, or, you know, having a conversation with us. You know, we can we accept self-referral, so we just having that conversation. You know, we're here to kind of listen and give advice, and, you know, any concerns about that, you know, you should be, you know, having that conversation and being open with professionals. Yeah. Physical health deterioration. So these are really common symptoms when a young person's restricting, is that dizziness upon standing, chest pains would be getting concerned about as well when people are restricting and losing weight, blurred vision. Often they say, you know, they get lots of stars, and complaining of feeling cold. We're noticing as well that it's having a real negative impact on their life. You know, they're missing education, they're not socializing like they used to, they're becoming more withdrawn and spending more time in their room, and they're just acting quite secretively, and you feel like, you know, they're not acting as they usually would do.
And we know that teenagers, I'm just sort of thinking that, like, taking yourself up to your room. I was a terrible teenager and wanted to take myself up to my room. I didn't want to be around my uncool parents. But it's become more than that, like isolative in terms of maybe not even eating with the family like they used to, and saying, no, I'll have this up in my room, or I'll have this later. That's when I would sort of say, yeah, that is a concern, because it's isolation more than what you would kind of expect from a teenager.
And you're noticing that they're becoming more preoccupied about their weight, shape, and food. And again, part of that, I mean, I think we kind of have to normalize a little bit, you know, particularly with young people.
When you go through puberty, they do, don't they? They become more aware of their body. And
but they're, you know, it's becoming more than just, you know, talking about it with their peer. It's becoming more obsessive and more of a problem. And, you know, we do see purging behaviors. People do self-induce vomit, not necessarily because of their weight, again, then their weight, shape, or, you know, and concerns around that. Actually, sometimes they vomit because it's a coping mechanism. It's so
anxious that they just have to just get everything out.
But you're noticing that's happening more, and things just to be kind of thinking, actually, you know, this is a worry now. Yeah, maybe it's time to kind of seek help. So yeah, this is what, I don't think we're going to go huge amounts of details of these. I know that they've probably been covered a lot in other presentations before, but so this is kind of the sort of the main ones that we see that fit into that criteria. You know, when we're talking about the ICD-11, the diagnostic eating disorders, so the anorexia. So this is just, you know, summary. You know, it can be the significantly low body weight for their high age and their sort of centile, their developmental stage. They kind of changed it, didn't they? Because it used to have to be that a young person would fit that, have to fit the criteria for anorexia if they'd with a low weight, but now they're kind of saying actually the rapid weight loss, so it doesn't necessarily, you know, their weight doesn't necessarily have to be consistently low. It's about that rapidity, and actually we're seeing lots and lots of that, aren't we?
We're getting quite a lot of young people that are deemed healthy with their weight, but their behaviours in terms of managing that weight
and the weight loss
that they've then, you know, they've been in a healthy range and then they can rapidly lose it, can't they?
And we still may see them when they're in a healthy weight range, but how much weight loss and their cognitions and, you know,
the drive, and
it's really important that, you know, even if they're healthy weight, we still see that young person. And anything else that we want to kind of mention on there? So they may be that they're underweight, but because they just haven't gained weight like they should do on their centile. So we kind of always look at that, don't we, their centile charts, and we look back at previous weights they were and they're not growing, or they've gone down. yeah, they're not able to gain weight, and they're not eating enough calories. They may have those purging behaviors, the vomiting, misuse of laxatives, and again it is that fear of weight gain, and it's about that their perception of not wanting to gain weight, and they want to remain underweight, and it's just their whole lives, isn't it? You know, they strongly believe if they achieve a lower weight, they
They'll
will
be happier,
happy.
they'll be more popular, they'll be liked by others, people won't look at them and judge them. That it becomes a real important self-worth.
That's it, isn't it? That's their whole life.
Yeah.
And yeah, there's nothing else other than losing weight, and that's their 24/7 thinking. I want to go through again. Let me move this. So the bulimia, we don't see it.
We don't see bulimia as often, but I
think maybe because a lot of people can hide it, I guess, because if they're a normal weight, because the bulimia it's
usually someone of a normal weight, but they're involved in sort of constant vomiting that they can do quite secretively. So it's characteristic, hopefully it's been covered before, but it is covered by binge eating once a week or more over a period of, or at least once a month. A binge eating episode is a distinct period of time during which the individual experiences a subjective loss of control over eating. So they're eating noticeably more or differently than usual, and they feel unable to stop eating or limit the type of food that they've eaten. So that's what we
often see, like a young person's going to the shop, or they're up in their room and they're eating, or and then they're hiding packets of crisps. We often see young people, parents saying, there was all of these,
all this stuff is now gone, and from the cupboard,
and it's the secret part, isn't it? It's people not knowing.
It's accompanied by repeated inappropriate compensatory behaviours aimed to prevent weight gain. So that's self-induced vomiting, or misuse of laxatives or eminas, or engaging in lots of exercise. And they're also preoccupied with their body shape or their weight. And that also strongly influences how they perceive themselves, and what they think others will think of them as a result of what they look like. There's also a marked distress about the pattern of their binge eating and the inappropriate behaviours that they're using, such as exercise. And then there's a big impairment on an impact on their sort of relationships with those around them, so their family or their peers, and maybe not engaging as well in school. And then that young person also doesn't meet the criteria for anorexia nervosa.
So this is the one that we mentioned earlier, about the
summarise them, haven't we?
So the other specified feeding and eating disorders. So this probably one would fit kind of, I've done another slide next just to kind of show actually they're quite similar, disordered eating and OFSFED, because they might not necessarily fit that box. So these are the ones that don't kind of fit the anorexia and bulimia. So it used to be called, what we were saying, the eating disorder not otherwise specified. So these are the ones that we might be seeing, that like the atypical anorexia. So they've met all the criteria, but they haven't had the significant weight loss, or and their weight is actually a normal range. So we do see a lot of those young people, don't we? So they often, we call atypical anorexia, and binge eating disorder. So the criteria is met, but they don't have the same amount of frequency. Again, they're very specific to fit those actual eating disorder diagnosis. So the ones that don't quite fit in, they come in here. Bulimia, again, there isn't the amount of frequency. They're not, binging or vomiting the amount that diagnostic criteria is stating. Purging disorder, we see a lot of these young people actually, so they're vomiting, but to influence their weight and shape, but they're not binge eating. So after eating a normal meal, we see this a lot, don't they? And then they're vomiting. We do treat that, don't we? But I know that when they're kind of post-18, actually our adult, the April House, which is the adult eating disorder service, they actually don't treat purging disorders. So they're very much like, we kind of see a broad range of young people, you know, if they've got eating difficulties, disordered eating, or, you know, fits any of those boxes. Whereas with the adult, they kind of just kind of treat the anorexia and anorexia and bulimia.
And purging, someone purging, they may be able to kind of link into other resources to help them, because it could, you know, one would kind of argue that that purging after a meal might not necessarily be about sort of the anorexic kind of drive, or the eating disorder drive. It could be because of so much anxiety, or needing to do some sort of self-help resources around.
But they would warrant assessment, wouldn't they, with our team, and then we can kind of unpick that with them. So I put, so consequently, it's likely that a large number of people with disordered eating would meet the criteria for the OFSFED. Falling into this category does not mean that a person has a less significant problem with food, or that their difficulties exist without physical or emotional risk. So just because they don't fit anorexia or bulimia doesn't mean to say that actually OFSFED is still, you know, it's still very serious. You know, it still warrants treatment. It's diagnosable and potentially severe eating disorder that warrants the same level of support as all eating disorders. So I think that's really important to mention, that disordered eating, you know, it is significant and does, you know, need treatment. I'm not going to go into this one really, but a binge eating disorder, we've put that there. So it's eating large amounts of food, like we talked about with bulimia, but they're not doing the purging, so they're not vomiting afterwards, they're not excessively exercising, but they have kind of got those cognitions around their weight, shape, and their appearance. And then RFED, which I believe there's going to be a separate presentation on RFED. So we do, just to mention, we do offer assessment within our service for RFED, and treatment. Again, it's still being worked out, isn't it, across the city. But I guess I did an RFED presentation for Reminds like quite a few years ago, and it was a real blanket. No, we offer an assessment, we don't treat. I think it is different now, isn't it? I mean, we will treat if there is that. If
a young person's clearly underweight and clearly not they're failing to thrive, then we want to get involved to sort of help them.
We might be seeking our colleagues from the
paediatricians.
It is still being worked out. I'm sure you're aware, but you know, it isn't a blanket no, is it? We absolutely offer an assessment. We do give a diagnosis if that's appropriate, but we only really see if they are underweight and they're failing to
meeting that
thrive.
Kind of that curve, that lovely growth chart.
So we won't go into this unless you want us to go into any more of this. Jill, would that be helpful? Or?
No, I think that's really useful to have the visual thing. And we had to talk last week, I think. So we've got a video all about that. But no, that's helpful just to have it there. So thank you.
Sure.
So just to make you aware that we do see that, and you know, we know that it's an important eating disorder. So
absolutely. Are there any risks to disordered eating? So someone that's disordered of eating, it does put them at a high risk of developing other physical and mental health conditions, including more severe eating disorders. So other consequences may include the sort of concentration and ability to focus. So people describe spending a huge amount of time thinking about or planning food and exercise, and time that they, you know, could and should be spending focusing on other things such as their education, their schoolwork, even, you know, socializing with their peers and doing other things outside of school. But they're so focused on having to look at their food and what they're doing that they're not able to engage in that. So, and again, as we've gone into social life, so socializing is often limited due to their anxiety about eating out in restaurants, eating out in front of others, and they have a prioritization of exercise. So they feel that they have to do their exercise rather than go and socialize with their peers or their family. So coping skills, so diet and exercise often starts as a way of coping with difficult life events. I think many can also, especially with COVID and the lockdowns that consequently came about that, there was a lot of focus, wasn't there, really, on doing exercise. Joe Wicks, bless him, you know, he did his daily exercise PE thing. We were given permission, weren't we, to go out for our walks or our runs. That was the only time we could leave the house. So I think also that did become, especially in lockdown for a lot of people, a coping skill with what was going on around us, and that is what we see even now with someone that's disordered with eating, is exercise and eating becomes a way of coping with what's going on around them.
And most young people were fine, you know, they coped, and you know that was fine. It was good for them to exercise. But those ones that are vulnerable to an eating disorder or vulnerable to mental health difficulties, that was a real kind of trigger, wasn't it? So you know, there is that vulnerability really with eating disorders, isn't it?
Yeah, and you know, exercise or maybe being a bit disordered with your eating can be seen like an effective strategy in the short term, but then it can become bigger, can't it, when it becomes something that they're doing more often, and not able to just stop like that. It becomes part of their life, and it actually then prevents them from having other healthier ways of coping with their emotions or coping with life. Life isn't easy. It's not an easy kind of path, is it? There's going to be sort of turbulent times. It's going to be some kind of ups and downs, or whatever cheesy way you want to describe it. So disordered eating or excessive exercise isn't the best way, is it really, for coping? It might be a short-term thing, but by being so engrossed in that, they're not able to find other healthier ways. And difficult emotions, so thoughts about food and weight, often start to become anxiety provoking, and it puts people at a risk of depression or chronic anxiety.
So what support is out there? So I think if you're concerned about physical health, you're concerned about weight loss, you're concerned about they're complaining of physical symptoms, we need to get them checked out physically. What's really helpful for us when having a referral into the eating disorder pathway or CAMHS is to have that physical health. We get so many referrals, don't we? Without that, and it's so difficult because we've got quite a strict criteria in how quickly we see people. So anyone that comes in our pathway, in the eating disorder pathway, we want to see within a month. That's for routine. If we're really concerned about someone who's lost a lot of weight over a short period of time,
or is really underweight
or severely restricting, we were going to see them in a week. And it actually, if we're, you know, they are having those chest pains, they've lost, you know, really, really quick weight loss, we're going to be asking them to be seen at the general hospital under our paediatrician. So without that information, it's really difficult for us to make that judgment of how quickly we need to see them. And we know
and we want to get that right, don't we? So that's where it's really helpful. We don't want to kind of miss someone actually being really poorly and not seeing them quick enough because we haven't had that check. So whilst we've said, haven't we, that someone being underweight can still be deemed anorexic, so you know, it's not all about the weight, but for this, for us to make the safe call and to get it right for that young person, we need the physical health check. We need to know what their blood pressure is doing. We need to know what their weight is. And we need a bit more information, don't we, really? So
it's all about early intervention. If we can get in there quick, the better outcome for that young person.
Absolutely.
So referral to Solent CAMHS West. So we have a wellbeing hub, so trained people in there that can triage eating disorder referrals or with called CAM referrals. So that direct route can come into either the eating disorder service or other pathways within CAMHS. So that first port of call, it may be that they think actually it'd be really helpful for having an eating disorder assessment, and then it comes to our pathway, and then we make that assessment about how quickly we see that young person. And then again, we might see them and actually think, no, this is not the primary cause of the issue. Or it may, we'll do that assessment. We might say, actually, we'll offer a bit of kind of psychoeducation around kind of healthy eating, but actually this isn't the main issue here. It would be better off at, within our
anxiety
pathway or our DBT pathway, or actually, this is trauma-based, this would be better at Yellow Door or something like, it's for us to kind of think about with our wider team. But it might be that we offer a short piece of work, or actually, no, this is disordered eating that actually does really need to be treated within our pathway. So it's just about kind of us doing that assessment and understanding. you want to say a bit more about the feast? There's a
so there is a resource out there. We've put the website there. Feast. It's a 30-day kind of, they call it a 30-day course. It's not all day every day, but over 30 days you can tap into kind of sort of a course workbook about kind of managing disordered eating, and it's aimed for eating disorders, but it's really helpful for any family really that's got a young person that's disordered with their eating to kind of tap into and learn from. So there's the website there. Do feel free to have a look at it. It's free and it's easily accessible. So
and we've got no limits. So if it, we're kind of assured that actually this isn't an eating disorder, but it's, they're a healthy weight, they're physically not
doing
compromised,
okay.
they're doing okay, they might have had some psychoeducation within our team, actually their eating's back on track, but they've actually they're still kind of needing a bit of more support,
still
around,
prone to kind of maybe going to their disordered eating kind of behaviors, because even though they've had the education for us, there's still something underlying that they're not managing. So yeah, we do, we link in with other services around us. So No Limits, we may sort of say actually it'd be really appropriate and helpful for you to join their emotional coping skills group, so that you can learn some other strategies rather than going to that safe one that already, that you've tried and tested.
And then there's some information on BEAT as well, that's kind of covers kind of all eating disorders and disordered eating on there. Maybe some pastoral support school, public health nursing can do some work around healthy eating.
They can, yeah. There is a bit of a waiting list, we understand, from the public health nursing doing that healthy eating, but they are able to offer that, or they're able, in the first instance, if they can't sort of do that individual work, they can offer some shared resources with parents around kind of getting back on track as a family with eating regularly and healthy, and that including then the young person that's struggling. The next. So the strategies to support any issues. So we've kind of condensed what we would share with our families that we see for anything now, don't we really, but those that we share within our sort of, we've got a purple folder with information to help our families with eating disorders. So we would say what's really helpful is to normalize eating, and that includes eating together as a family. We are seeing so many with disordered eating or with any eating disorder, but they're not eating together as a family. We know family life is very different than it was many years ago. Lots of us were having to work, having to juggle a lot more responsibilities now, but in trying to eat together, it doesn't mean do it for breakfast, lunch and dinner all day every day, because we know some are at school, some are at work, but trying to at least have a meal together a day really helps normalize it. It's about eating together, it's a social event, it's
coming
not
together
about,
and talking about our days, and as much
really key, really key. And encourage regular eating with at least 3 meals a day. We do hear often many say, oh, we don't normally have a breakfast, never have done, and we'll get that from the parents as well. But if you can just try and encourage your child to have that breakfast, to have at least 3 meals a day, and maybe I would sometimes say to some parents, maybe you need to be trying to do that too, because it's about kind of, it's that, what's the word, I feel like I've lost my word.
Regular eating,
but like as a parent, it's you're role modeling, so you don't I'm not saying to a parent, oh, have a massive bowl of porridge, but at least have a cup of tea and maybe just a start off something light, build up. Yeah, absolutely, just to sort of, it's that, like you say, role modeling.
And it's getting that blood sugar level, it's from waking up, you've gone all those hours without eating, and it's about starting right, isn't it? And and I think I was talking to Rachel, our dietitian, the other day, and she was saying eating every 2 to 3 hours ideally, to keep that that sugar level normal,
regular,
because having low blood sugar levels can impact on behavior and
your mood, and you kind of, and that also has an impact on your emotional regulation, doesn't it, on how you're coping. So it's important to schedule meals and snacks at a predictable and consistent times throughout the day. That can be really helpful. So we're not saying it has to be, you have to have lunch exactly at 12 o'clock all the time, or you have to have dinner at exactly 5:30, but they're thereabouts, not sort of making it sort of really, really messy and confusing. If it's quite predictable, it makes it a bit easier to then engage in it. And it does help develop more healthier eating patterns. And I truly believe it also helps. It helps regulate your body, and it helps, because we do often hear after a period of time of not eating regularly that they've kind of lost the hunger cues, that they kind of don't know when to eat. So by eating regularly, your body will then learn to get those cues again and start.
And it's also about, as parents as well, and families and carers, taking control back. So with disordered eating, it's about them taking control. Actually, as a parent, no, you're taking control back. You're going to be insisting that they're eating. It doesn't have to be loads. And a lot of our young people with disordered eating don't have to gain weight. It's also sometimes it's just about maintaining their weight for some young people. So it's about, rather than putting them on a prescribed meal plan that we do with our young people who are underweight, sometimes just having those kind of that schedule a little bit can help.
Absolutely. So again, as all meals should include a balance of the carbohydrate, the protein, the vegetables, and the fat source. So the kind of the healthy eating plate, we would sort of say, stick with that kind of thing for each meal. So monitor what the young person's eating. So keep tabs on what they are having, what they're bringing home, what they're missing out on, what they may be hiding and taking too much of. Just have a bit of a beady eye on it. Encourage and reassure them that eating is okay. We need to be eating. It is cheesy when I sort of say to young people that you wouldn't expect your car to be driving without the oil, without the petrol. We do need the water in the wiper blades. I'm trying to sort of touch on everything that car kind of needs to function. We wouldn't expect you to not have the same elements from the food groups and from fluids. You need it to keep going, otherwise you're not going to be able to get through the day. Like your car wouldn't be able to drive you from A to B. So yes, it's a cheesy, but it's the only one I could come up with. And we've used it quite often. So enforce boundaries. Boundaries is really key. I mean, it is even key with many young people with an eating disorder, but also with disordered eating. It's having that boundary as a parent to say, no, you're not. I don't know. You're not going to go. You're not going to go out on your bike for your regular ride because you've not eaten your dinner. Having that clear, strong boundary. If there are any concerns with vomiting, then we would say to families, stay with that young person and supervise them for a period of time. So if you're concerned that your child eats but then goes off and to the toilet straight away, and you think that they're going to try and sort of vomit, stay with them, try and engage them in a sedentary activity, watch a film together, sit down and play a board game together if you can.
Fidget toys.
Anything, just get them to engage in, I don't know, they might like arts and crafts. So stay with them. And I'm not sort of saying you have to stick next to them exactly, but in the same sort of room and kind of keep tabs on what they're doing. And if they try to go to the toilet, you just need to say no. Not yet. Give them about an hour after a main meal is what we kind of advise, isn't that? And after, if they have a snack or anything, half an hour. And try not to sort of demonstrate your own concerns about weight or body image. I think many of us, we may have insecurities about our own body, but try not to kind of project those concerns onto your child and talk about them so much all the time, especially with young people when they're going through all the changes with puberty and they're finding themselves. They're really, really sensitive to that. So it's not like I'm trying to sort of say to you, don't absolutely ever talk about it, but it's just be really mindful about how much of it you are sort of sharing with them about your own body.
And it's really difficult though, because we do live in a culture where people, may have, particularly with COVID, people have gained weight and then they're joining, they might be doing it in a really healthy way, they might be doing, there's like Weight Watchers Slimming one, they might be doing that as a way, because actually for health reasons, they need to lose weight. But that with someone who's quite vulnerable to that might trigger them to kind of have difficulty around eating. So it's about getting that balance. It's really hard. It is really hard. No, people do need to lose weight for health reasons, but then it's just being mindful of the impact that
and a young person typically wouldn't need to be losing weight,
no.
really. So
unless they're
really, but anyway, that's another
issue.
But yeah, we feel quite passionate about not projecting your own concerns about yourself onto your child, and we would say, we know that grown-ups, adults also might be using some diet foods, or just be mindful about having those in front of your child. I'm not saying completely hide it, but if you're having like a low-fat yogurt, for instance, try and make sure that they can't see the lid and that it says low fat when they're having maybe their thick and creamy or whatever. And encourage emotional coping skills that are positive. So there's plenty of resources that are available out there about other coping skills that they could do. So just encourage them.
They might have done that no limits group, or they might be on a DBT program. They might be in therapy. Encouraging them to use those different skills. And that's it. Wow, I think we've done. I know. So any questions? Oh, there's some chat things there. I don't know if we've got any. Okay, let's have a look.
So.
Okay, so we've got, yes, that's what I had for my son. He's 9. He had an emergency check. Yeah, we're really lucky now, actually. So once a week on a Wednesday, we now have our consultant paediatrician working within our eating disorder pathway now. So rather than us always, if we can assess risk, we can have that direct conversation with this paediatrician and say, we're really concerned about this young person. Do we need to send them down to A&E? But then actually working with her, she may be able to hold that risk and say, just book them in to clinic with us. Obviously they need to kind of be fitting under our pathway, but if there are that concerns, we can do that a bit more of a physical health assessment. Okay, someone's saying thank you to the speakers. That's helpful. Thank you.
Of body and bones hurting lately. I feel sick and dizzy a lot. How do I go about this? He's 9.
I'd say first port of call, going to your GP. Have a physical health assessment, GP, and they can, because it might not be anything to do with
his body and bones hurting. I'm just sort of thinking, when my daughter was 9, she would say that they're kind of going through growth spurts, so they might be a bit more sensitive to that. But definitely first port of call, if he's also feeling sick and dizzy a lot, I would go to the GP. I think it would be helpful to get a blood test. Because if he is quite restrictive with his eating, he might be lacking things like iron, vitamin D. That can also cause sort of some deficiencies that can kind of cause those. So go to the GP, and the GP can kind of do a bit of an MOT, and then if you feel that it might be helpful to see someone else about it, then do come to us.
I was saying I got a diagnosis from CAMS, so my son.
Hello.
Sorry, did someone say anything?
Yeah. My thing doesn't work, so I can't put my hand up or anything.
That's just fine.
But I've got a daughter which she's really fussy eater. She's waiting for a possible autism assessment, because I've got one child with autism already. She literally will only eat stuff that don't make any mess on her plate. So, like chicken, chips, dry pasta, cooked obviously, but with nothing on it. But it has to be like well separated. But recently we're having a problem even with trying to get chicken into her, because we did a roast, we did chicken, made sure there was no like skin on it or anything like that, and she was taking the most tiniest bit and she would put it to her mouth, and she'd have a can of Coke there, and she'd be like knocking back the Coke as if she was trying to take a tablet or something, and then she was kind of gagging on it. And she just says that she just doesn't like it because it's not battered or anything like that. But if she has a chicken nugget or something, she'll eat the batter first and then eat the chicken. So it doesn't make. Do you know what I mean? She's really kind of fussy on that. So I don't know if she kind of fits.
Is she underweight or is she growing okay?
No, she seems to be okay, because I've got as I say, one with autism, which is like severely overweight. So she seems to be growing okay, from what I can gather. But she say she wants breakfast, she'll maybe have a mouthful. Dinner, I found that with the school, because they don't do things plain enough, she's literally leaving it or bringing it home or binning it or giving it to her friends. So I've had a word with the school about that. And then she'll come home and she'll expect dinner and she'll be timing it to the time. So you have to go, yeah, be ready in a bit. But how long? Do you know what I mean? As soon as she has dinner, she could whiff that down. And I mean, totally eat it. Sometimes you have to say to her, look, you can breathe in between. And then after that, she'll have more food and more food and more food until it reaches bedtime. And then all of a sudden she just stop. It's like that constant conveyor belt.
So I wonder if, because she doesn't sound like she's eating very much at school, so she just like really hungry.
Yeah.
So did you say she has school dinners at school?
She'll have school dinners, but the school she's at now is like a bigger school. And I've spoke to them many times about her diet and saying, look, she's really plain, so it would have to be something like a ham sandwich or a chicken sandwich with no mayo and stuff like that. And they only do like 2 different types, and if they're not first in the queue for it, you don't get it. So, and if she gets anything else, she leaves it. I mean, the school have said to me before, we've been watching the new kids and we have seen people leave stuff on the table. And I was like, yeah, it probably has, because she hasn't eaten it today, or they've been it, you know, so.
And I'm just thinking, I wonder if you could ask for her to get her lunch first then, if she's struggling.
I've done that for a while and she's had like a 5-minute early pass.
Yeah.
That did work for a few days, but because she's continuously eating the same thing and she's not that keen on it, which is like the hamburger, she started like either only having a couple of nibbles out of it or just giving it to her friends. So she just don't. And even if I made her something, it would be similar lines, you know, the ham or the chicken sandwich, because she does the variety of food that she eats is just so minimal that it's just hard to get her to eat. And when I spoke to the doctors before, they said about putting a little something of what you're eating on the side of a plate so she can like see it, smell it, play with it, whatever. But if you do that, she'll just take offal. She won't eat her dinner if you put it on the actual plate, because she's so fussy how she has to have her dinner set up anyway. She's, you know, so like if she's got rice and the rice has got peas in it, she'll take the peas out and she'll separate it all in different bowls, and she'll have to have a different spoon for the rice and the chicken for, do you know what I mean? She's really fussy like that. And I said, we are waiting for an autism assessment because we know the other one's got autism and she does similar, but she's not.
And it may be that it's linked to that, isn't it? And I think and I think there's no really easy answer. I think that's the gap, isn't it, really, within services, isn't it? Because actually she is growing okay. So, you know, where that fits. I don't know whether they would, you know, would your GP refer for a dietitian, and would that change? It might be worth seeing what the GP would do. But again, I hear what you're saying, because actually you don't, you know, she needs to be eating at school, doesn't she? So that needs to be worked out about, you know, whether she takes it from school or it's difficult, because if she's eating the same thing and they're not eating it.
And it's trying to get her to try different things, because she just look at it and go, no. Or, you know, even for instance, the chicken, it's like it was plain chicken, but she was just taking the tiniest bits and just like, it was like smaller than a tablet, and she was just gagging on it before it was even in her mouth. And it's like, what are you doing? Do you know what I mean? It's just chicken.
And if it is autism, we know that her trying new foods is going to be quite a battle, isn't it, really? Because they do like that beige food, don't they? And that's not an easy answer.
It is a hard one, because I've got the other one on the actual autism diagnosis, you know, totally on the spectrum, and she will eat anything, but she's the other way. She's real big built, so it's not good for her. We've had a weight battle with her for a while, and she will just literally go through food. So say like she's into bacon, she'll literally go bacon sandwich, this, do you know what I mean? And then the next minute, I don't like that.
It presents so differently, doesn't it? There's such a different kind of
so I've got different kids. So meal times for me is is horrendous because I'm like cooking three different things.
Oh.
So, but I didn't know where the youngest one without the diagnosis actually fits in, because as I say, she's not been sick, she's not underweight, but is she not underweight because she's snacking or eating,
making up for it for the rest of the day, isn't it?
Yeah. And it's the kind of foods that she's eating are really no good for her, but I haven't really got much of a choice but to give her some food, because otherwise she wouldn't eat.
Is she on a multivitamin or anything as well?
No, she doesn't like tablets or anything like that. She's really, do you know what I mean? Kind of hard work, that one. But she just basically eat, it's got to be battered chicken. Most nights it's battered chicken of some sorts, whether it's dippers or fillets or whatever. And then she'll eat sweet corn with a little bit of butter on in a separate dish. And it will either have to be boiled potatoes with butter on, but then the chicken's not allowed to touch it. Or she will have like chips or dry pasta. But that's her meal. That's all she'll eat, or she'll eat some rice without any bits in. But she's literally so fussy that I can't do curries, lasagnas, shepherd's pies, none of it. She won't eat it.
Jill, did you say the dietitians did the ARFID one last week?
Yes, yeah,
they did. Give any tips around that?
Yeah, there's quite a lot of advice and sort of things to try, very practical things that might be worth trying, Charlotte. I don't know if you've had a chance to see that one.
I haven't yet, no.
I would definitely have a watch of it. There's a few issues with sound, but if you can sort of persevere, especially the last sort of section is all about practical tips. Your daughter sounds a lot like my daughter. I think it's quite a common thing, particularly when there's potentially autism around. But yeah, have a look at the ARFID one and see if that's got some things that might be worth trying. It's got some real good strategies to use.
Is that online? Is it?
Yeah, it's on our YouTube channel.
I mean, because the ARFID diagnosis, there's quite a rigid sort of criteria, isn't there, to meet? So it sounds like your daughter's got a reasonable variety in some respects, even though it's not what we would want. But she's having things like sweet corn. She's having spage chicken nuggets. She's having chips, rice, plain rice. So if we're thinking about food groups, she might not totally be able to fit the ARFID criteria, but there'll be a lot of advice from that kind of from that work that could help you.
It is frustrating as parents, isn't it, that where your child won't eat all of those things, but it is quite normal, isn't it, really?
Yeah. And what was the name of the channel again?
I'll put it on Facebook in a minute. It's
okay.
youtube.com/remindcic.
Same as well, isn't it, really?
Okay.
Yeah, have a look at that, definitely. And we're looking at from another Gemma, hello Gemma, about someone not eating hot food or carbohydrates, no meat, hardly any dairy, its weight's fine, health checks come back okay. I do visual charts and kilo boundaries, but still nothing really. So we would sort of say, look at the ARFID kind of support and help out there.
Gemma, does your son have ARFID or autism? Or was she gone? My son. Oh, he's been referred to dietetics through PEDS. Okay.
Yeah. Diagnosis assessment, right? So okay.
I think the PEDS can still do I think they can still do a diagnosis for ARFID, can't they?
I thought so. Any others? What's up that one? We missed one up there. What is the emotional workshop?
So if you go onto the No Limits on their website, you can do referrals. And they're currently doing an emotional coping skills group. So you can make a referral. I think we could add it to the chat box, couldn't we? Actually, I could find the
thingy.
Yeah, but I don't know if they give a list, but I know because we have No Limits workers within our sitting in the wellbeing hub, and I know there are groups I just can't remember how you refer. I think you can do an online,
Let me get it up.
I think there's a referral form
Yeah.
you can say about doing the emotional coping skills group. You can refer yourself, you can phone No Limits number, but you can do it online as well. We can pop that on the chat. Yeah.
Yeah, just put their website, because they've got a get help section. You can refer yourself, refer a young person. There's drop-ins from the advice centre. So yeah, referring you, usually it's just a blanket referral to No Limits now, just online. So if we put in their website.
Thank you. That would be really useful. I will get that and share it. I'm going to stop recording